31-year-old man. Okay. 31-year-old man with a history of alcoholism brought to the emergency department because of severe abdominal pain, mild nausea, 2 episodes of vomiting during the past 16 hours. The pain is located in the epigastrium, radiates straight to the back. He had similar episodes of pain 2 years ago, was treated with fluid and hydration and bowel rest during the 2-day hospital stay, but he left against medical advice. Vital signs are within the normal limit except for a temperature 100.1 degree Fahrenheit. Abdominal examination show slight distension, mild epigastric tenderness. The liver is non-tender. The age is non-palpable. Sorry, the age is palpable at the costal margin. The spleen is not palpable. Bowel sounds are hypoactive. Tests of the stool, occult blood test is negative. Insertion of the nasogastric tube yields a green tinged fluid. His leukocyte count is 18,000. Serum amylase is 350. Liver function test normal. Which of the following is the next step in management? Is it pancreatitis?
Probably.
Okay.
The CT scan of the abdomen. Acute pancreatitis typically presents with epigastric abdominal pain that adheres to the back, along with nausea, emesis, and often with the patient history of gallstone. Often in a patient with history of gallstone, alcohol use disorder, trauma, hypertriglyceridemia, hypercalcemia. Lab evaluation often discloses increased amylase and lipase concentration. Treatment of acute uncomplicated is supportive and should include IV fluids, either normal saline or lactate ringers. Bowel rest in addition to pain control. The associated pain from acute pancreatitis is severe and requires opioid analgesics. Acute pancreatitis can be complicated by necrosis, hemorrhage, abscess, or the formation of pseudocysts. This patient with severe pain, leukocytosis, and fever may have pancreatic abscess. CT scan of the abdomen is the gold standard for diagnosis of pancreatitis-related complications such as abscess and hemorrhage. Treatment of such condition may require surgical intervention. Abscess should be treated with antibiotics and source control. Next.
Okay. 24-year-old man comes to the office because his fiance had urine analysis 2 days ago, not confirmed. Uh, 2 days ago, that confirmed the presence of Trichomonas vaginalis. They are sexually active, use condoms inconsistently. He has had urinary insufficiency. He has had not urinary insufficiency, painful urination, dark urine. Uh, he has no history of serious illness, takes no medication, has no drug allergy. Vital signs are within normal limit. Examination show no abnormality. Which of the following is the most accurate?
We do the swab or we give the medication.
Is it like honeymoon cystitis?
What do you mean? No,
Like there is a such kind of cystitis after just after
no, he has to, it's like a
trich
STI. Yeah, they're trying to know
trichomonas
if
vaginalis.
no. Ready?
Yes, metro is the drug of choice. Okay.
Trichomonas, give metronidazole therapy. Trichomonas vaginalis anaerobic flagellated protozoan that causes vaginal trichomoniasis. A trichomoniasis is a STI that presents with pruritus, dysuria, dyspareunia, cervical erythema, normal discharge that is described as green 40 and malodorous. Trichomoniasis can also lead to overactive bladder, frequency, urgency, urge incontinence. Vaginal pH is above 4.5, and motile trichomoniasis can be visualized on wet mount preparation. Men affected by trichomoniasis are often asymptomatic but may transmit the disease while asymptomatic. Oh. Therefore, treatment of patients and their sexual partners is necessary for trichomoniasis. Metronidazole is the treatment of choice. As with other STIs, patients should be broadly tested for HIV, syphilis, hepatitis, gonorrhea, chlamydia, because such conditions are often jointly transmitted and may be asymptomatic. It's not B, C, or it's not B, D, or E. Follow-up exam if it becomes symptomatic would not be appropriate. Asymptomatic infections are common, and with confirmed exposure to trichomonas, empiric treatment with metronidazole is necessary. Further diagnostic testing with urethral swab or urinalysis will not be necessary because partners of patients with STIs such as trichomoniasis should be treated empirically. Okay, next.
70 72-year-old woman with multiple myeloma brought to the physician because of one-day history of shortness of breath and fatigue. Respiration 20 per minute, blood pressure 120 by 60. No orthostatic changes, lungs are clear to auscultation. Cardiac examination showed decreased heart sound. Uh, On the remainder of the examination showed no abnormality. The serum BUN is 36, creatinine is 5.1, creatinine high, BUN high, protein 3 plus, RBCs nil, WBC FeNA more than 1%, and post-viral residue 50. A 24-hour urine collection is 3.5 gram of protein. Creatinine clearance is 10. Which of the following is the most likely cause? FeNA 2%, one more than 1%. Modern renal renovascular. Is it a renal, pre-renal? It is, isn't it renal? What acute tubular necrosis? This because FeNA is more than one. What is your thought?
I'm between B and D, like renal parenchyma disease or congestive heart failure. But congestive heart
Heart
failure,
failure would have like lung finding, like crackles.
yes,
Oh,
true. Okay,
or
there's
hepatomegaly. Like congestive
a,
heart failure is right heart failure, isn't it? So hepatomegaly foot edema should be present.
yeah. Ready?
Yes.
Okay, so it's renal parenchymal disease. Multiple myeloma. Okay. Multiple myeloma is a malignancy caused by neoplastic proliferation of plasma cells. Neoplastic plasma cells overproduce monoclonal immunoglobulin and light or heavy chains, which may result in acute renal failure caused by protein deposition and damage of the renal tubules. Multiple myeloma results in amyloidosis caused by overproduction and deposition of immune globulin chains in the kidney, heart, brain, and other organs. Renal amyloid deposition on biopsy discloses deposits in the mesangium. Multiple myeloma causes an increase in kidney injury, resulting in increased creatinine and proteinuria, caused by Benson-Jones protein immunoglobulin light chains in the urine. Prerenal and intrinsic kidney injury can be distinguished by the fractional excretion of sodium. which is less than 1 in perirenal and more than 1 in intrinsic kidney injury. Intrinsic parenchyma kidney disease is characterized by an increased fractional excretion of sodium caused by inability of the PCT to reabsorb sodium. Lab evaluation will also disclose BUN to creatinine ratio that's less than 20%. Treatment is supportive. The patient may require hemodialysis in severe cases. It's not A. Bladder outlet obstruction will result in postrenal azotemia from obstruction of the urinary outflow from the bladder. Postrenal azotemia occurs when outflow from the bilateral kidneys is obstructed because of underlying pathologies such as bladder cancer, prostate cancer, or hyperplasia, urethral stricture, or bilateral ureteral fibrosis or stricture. And it's not E, renovascular disease, such as renal artery stenosis. Decreases renal blood flow, causing acute as well as chronic kidney injury. Renal artery stenosis is a cause of secondary hypertension related to activation of the RAS. This patient blood pressure is normal, making renovascular disease less likely. Okay. Additionally, the insult occurs prior to the level of the kidney, resulting in fractional excreta of sodium that's less than 1%, and ratio of urine creatinine of generally 20 or above.
Okay,
Okay.
next. 27 year
Mm-hmm.
old 27-year-old man because of 3-month history of progressive generalized swelling. He had 10 kg weight gain. He had 10-year history of heroin use. Smoked 1 pack of cigarette for 13 years. He has hepatitis B 10 years ago. Mitral valve infarctus 2 years ago. HIV is negative for 1 month. Temperature is normal. Pulse 100. Blood pressure 150 over 110. Examination shows no JVD. There is bilateral basilar dullness on percussion, and breath sounds are decreased. Bilateral basilar dullness on percussion, breath sounds are decreased. A grade 2 by 6 hollow systolic murmur is heard at the apex that radiates to the axilla. Examinations show a protuberant abdomen with a fluid web. There is 3 plus pitting edema to a lower abdominal wall. Scrotum is markedly edematous. Labs show serum urea nitrogen 38, glucose 154, creatinine 3, albumin 2, cholesterol 280, total bilirubin 1, AST 250, ALT 35, C3 is normal, C4 is also normal. Hepatitis B surface antibodies positive, hepatitis C antibodies negative, urine protein is 4 plus, RBC 50, high powerful WBC 8, there is no RBC cast, granular cast is occasional, leukocyte esterase is 2 plus. The most likely explanation for this finding of nephropathy induced by which of the following? 4 plus from
Cholesterol 280.
granular dullness on the question do with some decrease. What is your diagnosis?
I don't know what's the diagnosis.
Protuberant abdomen with a fluid wave. Is it like CLD? He has
What is
chronic, like chronic liver disease.
um it's chronic liver disease, but why would the lungs have an issue on chronic liver disease?
Chronic liver disease, the fluid can go to the lung and can cause liver problem.
Mm, don't make that much sense. Looks like heart failure kind of thing.
Then what is the cause of this heart failure? High
Mm,
cholesterol.
I feel like either cholesterol or his heroin thing. But I don't know if cholesterol causes any type of nephrotic syndrome.
I, and that is 4 plus. Very absurd.
Yeah, he has nephrotic syndrome. So I
Yes,
don't know. And his HIV was negative, right? It's
yes,
negative. So I feel like it's heroin though. Let's see. Ready?
yes.
It's heroin. Heroin-induced nephropathy can have a variety of disease characteristics and clinical presentation. Heroin-induced nephropathy is often characterized by FSGS, which is a nephrotic syndrome. Nephrotic syndrome is characterized by edema secondary to excessive proteinuria, resulting in hypoalbuminemia and diminished intravascular cortic pressure. This occurs because of loss of normal size and charge filtration, capability of the glomerular capillary and Bowman capsule. Patients classically present with dependent edema in the buttocks, lower back, legs, ascites, foamy and dark color urine, hypoalbuminemia, and excessive proteinuria. Heroin can also cause MPGN, membranoproliferative glomerulonephritis, with immune complex deposition, which is a mix of nephrotic and nephritic syndrome. Oh, patients can present with hematuria, proteinuria, decreased complement concentration, and renal failure. It's not cholesterol, does not typically cause acute or chronic kidney disease, proteinuria, or nephrotic syndrome. And it's not it's not HIV because I'm guessing it's HIV negative. Can present with systemic constitutional symptoms during the acute HIV syndrome and following the clinical latent period. This patient does not have feature of HIV, and this will be less likely with a negative antibody assay. Okay, you want me to read another
No.
one? So, okay.
Next. One day, after undergoing chemotherapy of ALL, a 38-year-old man had an increase in serum urea nitrogen concentration 20 milligram per deciliter to 60. Urine sedimentation show crystal. Treatment with which of the following drugs prior to chemotherapy is most likely to have prevented for renal failure? Okay.
Allopurinol. Tumor lysis syndrome most commonly occurs following chemo initiation for leukemia or lymphoma. The abrupt destruction of many tumor cells results in interstitial and serum release of their contents. Okay, manifesting as hyperphosphatemia, hypocalcemia, hyperkalemia, hyperuricemia. Patients with tumor lysis syndrome can present with fever, nausea, vomiting, diarrhea, lethargy, cardiac dysarrhythmias, seizure, tetany, muscle cramps, syncope, and a risk of sudden death secondary to electrolyte and metabolite abnormalities. Urine nucleic acid are metabolized to hypoxanthine and xanthine, which are converted to uric acid by xanthine oxidase, resulting in hyperuricemia. Uric acid can crystallize in the renal tubule, leading to nephropathy and acute kidney injury. It can also deposit in the joints, leading to gout. Treatment of tumor lysis syndrome involves supportive care and correction of electrolytes. Rasburicase is used to promote the degradation of uric acid and is used in both prevention and treatment of tumor lysis syndrome. Allopurinol decreases the production of uric acid by inhibiting xanthine oxidase. In patients with severe kidney injury, and refractory electrolyte derangement, renal replacement therapy with dialysis may be indicated. Patients with severe kidney injury. Okay, and it's
Okay.
not, oh, can I read DE?
Yes.
Sorry. It's not D and E. Indomethacin and prednisone will be helpful in the treatment of gout, but will not help address tumor lysis syndrome and hyperuricemia. Okay. Next.
2 days after the onset of the mens, a 24-year-old man developed diffuse migrating pain on his wrists, elbow, knees, ankles, and pustules on her extremities. Examination shows slightly tender pustule on the upper and the lower extremity. A photograph of the right finger is shown. There is mild There is moderate swelling on the right knee. Which of the following is most likely to be effective?
Ready?
Yes.
Self-reaction. Neisseria gonorrhea is a gram-negative Diplococcus that can present with vaginitis, cervicitis, PID, disseminated gonorrhea. When causing vaginitis, gonorrhea typically presents with mucopurulent discharge and pruritus, although patients may be asymptomatic. Cervicitis presents with red, friable cervix with cervical motion tenderness. When it spreads to the fallopian tubes and ovary, it may cause tubovarian abscess, presenting as adnexal tenderness and adnexal mass. However, when it enters the bloodstream and spreads hematogenesis, it can cause disseminated gonorrhea. Disseminated gonorrhea presents with tenosynovitis, polyarthralgias, dermatitis, although septic arthritis may be the only finding. The lesions associated with disseminated gonorrhea are typically pustular, painless lesions on the distal extremities. One risk factors for the development of disseminated is recent menstruation, which is present in this patient. Oh. Treatment includes IV antibiotics with ceftriaxone. Empiric treatment for chlamydia and doxycycline is also recommended because of co-infection. Empiric testing for other STIs should also occur. Hmm, interesting. They say it's painless. The pustules are painless, but here they say that the pustules were painful.
Tender, yes.
Mhm.
What is the clue you have found in this question? Like polyarthalgia and tenosynovitis.
Oh, I don't think there was a. You knew, I knew it was a STI, and the only STI that comes with dissemination thing like with those things are is the
Neisseria.
Neisseria. Yeah, it's the only one.
But in the hand, like herpes can happen. In the hand, what?
But but herpes wouldn't cause the septic arthritis. It says that she has the migrating pain and on the wrist and elbows and all this the arthritis.
Like
Like
polyarthalgia. It is not septic
yeah,
arthritis.
yeah,
Like,
like the polyarthralgia. Sorry, herpes
oh,
wouldn't cause that.
okay.
Mhm. You said moderate swelling in the right knee. Sorry, that's what I was looking for. The swelling in the right knee. Yeah. Okay, next.
62-year-old man comes to the emergency department because of a 12-hour history of pelvic discomfort and inability to void. During the past year, he has had progressive difficulty initiating a urine stream, dribbles at the end of the urination. He has not received medical care for 20 years. He has no history of serious illness, takes no medication. He is 173 centimeter tall and weighs 86 kg, BMI 29, temperature 37, pulse 80, respiration 16, blood pressure 150/90. Then S for abdominal examination show lower quadrant tenderness. There is 2 plus pitting edema. HbA1c 8.9%. Serum sodium 140, serum potassium 5.8 high. Fluoride is slightly high, bicarbonate is low 19, BUN high, glucose high, creatinine 2.9 high. Which of the following is most likely increase serum creatinine? Why increase serum? I don't know. BUN by creatinine. Isn't it more than 20 or 15? No.
Hmm? Oh, you're trying to see if it's on.
BUN by creatinine.
Let
Is
me
it high or
see.
low?
52 over 2.9
2.9.
is 17.9.
So it is less than 20. It is renal.
The position in the kidneys.
There is S for hypertension. Uh,
Sorry?
wait 1 second. Okay.
Uh, is benign prostatic hyperplasia. Um, Benign prostatic hyperplasia is a common finding in older men caused by benign enlargement of the prostate surrounding the urethra, often secondary to androgen stimulation. Risk factors include age, family history, and obesity. Symptoms include difficulty initiating urine stream with occasional intermittency, terminal dribbling, and nocturia. Failure to empty the bladder can lead to overflow incontinence as well. Chronic bladder outlet also can lead to hydroureteronephrosis with the pressure preventing proper creatinine clearance by decreasing renal blood flow and causing glomerular injury. This is the most likely cause of these patients increased serum creatinine concentration. Medical treatment includes alpha blockers, such as tamsulosin, alpha 5 alpha reductase inhibitors, such as finasteride, whereas surgical options include transurethral resection of the prostate. It's not crescent. I'm going to read the other ones. It's not crescent formation in the glomeruli. Is in the glomeruli is a marker of glomerular injury and can be seen with inflammatory glomerular injury such as lupus or MPGN, among other glomerulonephritis. This patient has signs of chronic urinary outflow obstruction, which is the most likely cause of his renal injury rather than glomerulonephritis. It's not necrosis of the renal tubules usually occurs in the setting of hypoxemia, hypotension, and shock. It is associated with decreased perfusion to the kidneys and is diagnosed in the appropriate clinical context with muddy brown cast. This patient has no history of these factors, making acute tubular necrosis unlikely. It's not D because protein deposition in the kidneys is seen in amyloidosis, and the rise in creatinine is caused by protein interference with proper filtration. Amyloidosis can be inherited sporadic caused by long-standing inflammation. As it is relatively rare disease, it is less likely cause of renal dysfunction than BPH in this patient. Stenosis of the renal arteries can lead to renal dysfunction by decreasing renal blood flow to the kidneys and preventing proper filtration and creatinine. However, this is associated with significant hypertension because decreased renal blood flow leads to activation of RAS with fluid retention and increased BP. This patient is only mildly hypertensive and more likely has renal dysfunction caused by BPH. Mildly hypertensive. Okay, next.
Okay. An asymptomatic 67-year-old woman comes to the physician for a routine follow-up visit. A 7-year history of type 2 diabetes mellitus treated with diet. Her finger stick blood glucose concentration have ranged from 100 milligram to 140 milligram during the past 6 weeks. Her pulse is 80 per minute regular. Blood pressure is 118 by 82. Examination show no abnormality. Hemoglobin 12, HbA1c 7%. Urea nitrogen 18, glucose 115, creatinine 0.8, total cholesterol 275, LDL 190, HDL 35, urine microglobulin negative. Which of the following is the most appropriate reduction in long-term morbidity and mortality in this patient? Is there any protein loss?
What do you mean?
HbA1c is quite okay. BP is also normal. LDL more than one. Okay. I am with I am confused with B and C. Is it like LDL is more than one? LDL is 190, so it is high,
Probably.
and
Yeah.
ACE inhibitor is given in case of diabetes, and it has a mortality benefit too. But his blood pressure is normal.
Mm-hmm.
There is no such protein loss. Okay.
Okay. Answer is reduction of the LDL cholesterol concentration. Diabetes mellitus is associated with a variety of complications caused by micro and macro disease. This complication includes cardiovascular disease, retinopathy, nephropathy. Goals for the management of diabetes include treatment of hyperglycemia, blood pressure, and cholesterol to prevent the comorbidities. Recommend targets for fasting sugar is 80 to 140, so 130, I guess, fasting, corresponding to hemoglobin or less than 7. Whereas those for blood pressure is systolic less than 130. This patient is meeting both goals, 7 and less than 7. Okay. However, LDL is out of the recommended goal that is less than 100. Oh, I thought it was less than 190. Okay. She will therefore benefit from reduction of her serum LDL concentration. In fact, statins are recommended in patients over 40 with a total
Diabetes.
cholesterol. Wait, patient, what do you mean?
Like the primary criteria, primary prevention, age more than 40 with diabetes. And the second criteria is like LDL is more than 190. The
Oh,
ASCVD therapy, you
oh, it
remember
says,
the box?
yeah, but here it says statins are frequently recommended in patients over age 40 with a total cholesterol concentration of 135 or greater to reduce the risk of cardiovascular disease.
This is new information
Yeah.
because on that box, I don't know you remember or not on
Yeah, I
that
remember.
box.
I remember. I remember.
I told you multiple times. That's why I
Yeah,
say so.
I remember.
Like
It's
on
not
that
just
box, like age for more than 40 with diabetes. So they are talking age more than 40 with, then the total cholesterol is 135 or greater, reduce the risk.
total cholesterol here was, yeah, it was more than 135. Yeah.
Okay.
ACE inhibitor therapy is often recommended in diabetic patients with hypertension and microalbumin. Yeah. In addition to decreasing blood pressure, it also has a renal protection. However, this patient is normotensive with no microalbuminuria, and lowering the LDL cholesterol will be important. And it's not glyburide because we still used to treat hyperglycemia in diabetic patients. This patient blood sugar is within control, and attempts to further decrease can lead to hypoglycemia. Okay, so LDL should actually be less than 100. I thought it was less than. Okay, LBS should be less than 100. Diabetes A1C should be 7 or less, and BP should be, where am I?
130 over 80.
130 over max, 130 over 80 max.
We should
Okay,
keep the BP below 130 over 80.
below 130 over 80. Okay, got it.
47-year-old woman end stage renal disease comes to the office 6 week history of pain in his right shoulder, pain in his shoulder and shin. He has received hemodialysis 3 times weekly for 12 years. Last received hemodialysis 2 days ago. Examination shows a thrill at the site of AV fistula in the left forearm and trace pedal edema. X-ray of the clavicle, X-ray of the clavicle and tibia show periosteal resorption. Which of the following serum components is most likely responsible for these patient symptoms?
Ready?
Yes.
PTH. PTH plays several important roles in calcium and phosphate homeostasis. PTH directly stimulates osteoclast bone resorption and DCT calcium reabsorption and phosphate excretion in the kidney. PTH also stimulates 1-alpha hydroxylase in the kidney, which leads to conversion of 25 vitamin D to 125, the active form. Once produced, 125 vitamin D stimulates the increased absorption of calcium and phosphate from the intestine. In renal, where am I? In renal failure, however, the kidney cannot respond to PTH, which breaks the feedback relationship and leads to excessive PTH secretion known as secondary hyperparathyroidism. The hypocalcemia and hyperphosphatemia trigger PTH secretion, which in turn leads to excess bone resorption known as renal osteodystrophy with resultant bone pain.
Okay. You want to read the other options too?
No. So PTH bone resorption. Then in the kidney, it absorbs both calcium. No, it absorbs calcium in it trashes phosphate, and then in the that's in the kidney, and then it
In
also
the
produces,
intestine, PTH
yeah,
has
the-
three role in the intestine, in the kidney.
and
Yes.
then the intestine it absorbs both calcium and phosphate through vitamin D. Okay, got it. Next.
5 days after undergoing surgical repair of middle cerebral artery aneurysm, a 52-year-old man comes with 52-year-old man progressive lethargy. During initial post-operative course, he was alert, only mild right hemiparesis. Currently, he is oriented to a person but not the place or time. Temperature 100, pulse 75, respiration 20, BP 130/80. No focal findings. Lab is leukocyte 7,500, platelet count 250,000. Low sodium. Sodium is low. Chloride is low too. Potassium normal. BUN 20. Glucose 130. Creatinine normal. A CT scan of the head show no changes. Which of the following is the next step? Severe hypertension. Okay. Think about the box. Severe hyponatremia.
Don't know. Okay, let's do it. Ready?
Yes. In, initially, what you are going to pick that was correct. I was watching.
Oh, no, I wasn't going to pick that one.
Oh,
This
sorry.
one, I'm
You
like,
were
I'm not.
scrolling your pointer in the C. That's why I
Oh,
told you.
obviously. No, I was lost in this one. Okay. This patient altered mental status is likely caused by hyponatremia secondary to the SIADH. Oh, okay. While commonly presenting as a paraneoplastic syndrome, SIADH may also frequently present in association with sepsis, pneumonia, or central nervous system trauma following surgery, as in this patient, or as an adverse effect of medication. SIADH results in increased aquaporin expression in the luminal surface of the renal collecting duct cells, which increases the membrane permeability to water, leading to inappropriate free water reabsorption, hyponatremia, decreased serum osmolality, and inappropriately increased urine concentration. The diagnosis is confirmed by measurement of serum and urine osmolarity and sodium concentration, by confirming euvolemia, and by excluding alternate causes of hyponatremia, such as hypothyroidism and adrenal insufficiency. The management of HIV/AIDS associated hyponatremia involves treatment of the underlying disease, restriction of water intake, and gradual sodium correction. If there are associated severe neurologic symptoms, administration of hypertonic saline may be considered to correct the sodium, although this must be performed with caution because of the risk of central pontine myelonitis, myelin, whatever. It's not B and E because B. Measurement of serum cortisol concentration is useful during assessment of hyponatremia to exclude the presence of adrenal insufficiency, which presents with hyponatremia in addition to and hypocortisolemia and hypoaldosteronism. However, measuring urine electrolytes is a more useful and essential initial step in diagnosis and evaluation of hyponatremia in the absence of other lab abnormalities that suggest a primary adrenal process. Ah. Intracranial pressure monitoring is not needed. Absence of interval change on CT scan and lack of neofocal neurologic findings suggest against recurrent intracranial bleeding and increased pressure. Hyponatremia secondary to SIADH is more likely cause of this patient altered mental status. Okay, got it. Next.
Okay. A 32-year-old woman comes to the physician because of 3 week history of joint aches. Over the past 3 months, she has had headaches, stiff neck, progressive numbness and tingling, and weakness of the lower extremity. Neurologic examination, mild right facial palsy, and mild weakness in the distal lower extremity. Sensation to pinprick and light touch is decreased over the lower extremity. Deep tendon reflex are absent. Which of the following is the most appropriate next step in the diagnosis?
Wait. 3 week history of
Is
diffuse aches, numbness and tingling
it
in
Lyme,
both lower extremities,
joint
headache,
pain, discomfort?
mild right facial palsy, and mild weakness of distal lower extremities. Um, Pinprick is decrease of the lower extremities. Um, hmm,
How do you think? What is your diagnosis?
mm, Definitely the A or B. Pimping, vibration, proprioception. Pimping,
B does not cause facial palsy, so A is the answer.
probably A.
Like
Yeah.
SCD, subacute combined degeneration, never cause the facial palsy, isn't it?
Uh-uh.
A-
Yeah.
And deep tendon reflex is absent. Think about the Lyme, the person who is circling and somebody is throwing arrow to the that man.
Mhm.
Okay, I don't know
Yeah.
what I am talking about.
Lyme disease is a tick-borne tick-borne disease caused by Borrelia. That is
These times,
endemic.
these days, I feel like I am hallucinating
We are hallucinating.
without taking anything. Trust me, I don't, I never do drugs. Okay.
Yeah, I do. I know, no, that I believe you. I do. I believe you. In its early stages, it causes erythema migrans, which is bandy rash with central ring-like clearing. It can also be associated with flu-like illness and arthralgia. Later stage of Lyme disease are characterized by carditis, AV block, facial nerve palsy, which is often bilateral, mononeuropathy, multiplex, motor or sensory radiculopathy, migratory arthralgias, and if left untreated, encephalopathy and chronic arthritis. Diagnosis is confirmed by measurement of serum antibodies to Borrelia. The early stages of Lyme disease can be treated with by doxycycline, which acts by preventing the attachment of uh, tRNA to ribosomes. Side effects of tetracycline antibiotics include GI distress, photosensitivity, and in children, discoloration of the teeth and inhibition of bone growth, which contraindicates the use of doxycycline in pregnancy. The later stages of Lyme disease affect the heart or the central nervous system and are treated with ceftriaxone. Next.
67
Next.
year, yes, yes. 67-year-old woman is brought to the emergency department 2 hours 2 hours after sudden loss of 2 hours after sudden loss of vision in in her right eye. He has had several intermittent headache over the past week. She has 3 months history of progressive fatigue and muscle aches that are most severe in the neck and the shoulders. During this period, she has had temperature to 100 degree Fahrenheit, 4.5 kg weight loss. He has 10-year history of hypertension, treated with Lisinopril osteoarthritis of the hips and the knee, treated with acetaminophen. Treatment temperature is 100.4 degree Fahrenheit, pulse 72, regular, respiration 14 per minute, blood pressure 132 by 84. Fundoscopy examination shows examination of the right eye show pallor and the edema of the optic disc. Pallor and the edema of the optic disc. There is complete loss of vision. The temporal area and the shoulders are tender. The remainder examination is normal. Lab hematocrit 32%. Leukocyte count 12,000. ESR 110. Sodium 136. Chloride 104. Potassium normal. Bicarbonate normal. And creatinine is okay. Which of the following is most likely underlying mechanism of this one? Okay.
Answer is B. Arterial inflammation. What is the thing? Patient presenting findings of abrupt onset monocular vision loss, headache, stiffness, and temporal tenderness consistent with giant cell arteritis, autoimmune inflammatory vasculitis of medium and large vessels. Classic findings include systemic symptoms of fever, chills, and weight loss, headache, history of vision loss, joint radication, tenderness on the scalp, and pale optic disc edema. New headaches in an elderly patient should raise suspicion of GCA. GCA frequently occurs in association with polymyalgia rheumatica, which is characterized by stiffness of proximal muscles. Lab evaluation discloses increased inflammatory marker, including ESR and CRP, and thrombocytosis. GCA is characterized by a predilection for the vessels of the head and neck, often affects the ophthalmic artery and can result in sudden ischemic damage of the retina. Once vision loss occurs, it is not reversible. It is and is commonly followed by vision loss in the contralateral eye within days of weeks. The diagnosis is confirmed by biopsy of the temporal artery disclosing granulomatous vasculitis. Treatment with high dose steroids occur immediately once GCI is suspected to preserve vision. Steroid treatment does not generally compromise biopsy results if the biopsy is done within 1 to 2 weeks. Next.
Yes. 78-year-old woman is admitted to the hospital. 3-day history of dizziness and weakness. She was diagnosed with CLL 2 years ago. Since then, she has had 13.6 kg, lives independently. She does not smoke cigarettes or drink alcohol on admission. She appears confused and somewhat anxious. She is oriented to person, but not place or time. Temperature is 97, pulse 90, respiration 12 per minute, BP 110/60, pulse oximetry on room air oxygen saturation is 94%. Physical examination show lateral nystagmus and pallor. No rashes are noted. Cardiac examination shows 2/6 murmur, heart over the best heart over the lateral, best heart over lower left sternal border. Romberg's test is abnormal. Finger nose testing is negative. Muscle strength is 4/5 throughout. Deep tendon reflexes are normal. She has an ataxic gait. Supplementation with which of the following is most likely prevented this patient's condition? He's alcoholic, isn't it?
No, where did you see that? Let me see.
He
It
has
does not.
only CLL.
Yeah.
Is it vitamin B1?
I was between that and B12, so I don't know. I think it's between one of the other.
Deep
Oh
tendon
wait,
reflex are normal.
wait, you're right. It may be because vitamin B1 is the Wernicke, which is nystagmus, ataxia, and what was the other one?
Lateral nystagmus, yes, ataxia. Deep tendon reflex are normal. Why vitamin B12? You are getting my
Okay.
point.
Yeah, right. You're right. It's probably B1 because B12
I
is
haven't seen your answer truly.
no, you're right because B12 will there is ataxia, but and then when it says Romberg test is abnormal.
Romberg's test is abnormal in this case.
But Romberg test is not for the columns. Romberg test is
Romberg test is for like any sensory ataxia. Like in sensory ataxia, Romberg's test is abnormal.
hmm, okay. Let's see. Uh, it's B1. Yeah.
I was
Wernicke and
looking
Seligman.
for alcohol. That's why I was distracted. But I haven't heard about the malignancy also caused by Wernicke.
Mm, Wernicke encephalopathy is caused by deficiency of vitamin B1, thiamine, most commonly in patients with alcohol use disorder, anorexia, malignancy, hyperemesis in pregnancy, among others. It presents classically with encephalopathy, ataxia, and nystagmus. This patient presentation is most consistent with Wernicke encephalopathy in the setting of chronic malnutrition, as evidenced by her weight loss in the setting of systemic malignancy. Prevention of Wernicke encephalopathy includes vitamin B1 supplementation, whereas treatment consists of giving vitamin B1. If untreated, it can lead to coma and death. It is not, where was the other one? Where was the vitamin B12? It's not what is it? Oh, folic acid or vitamin B12 deficiency lead to microcytic anemia, which is associated with fatigue, pallor, and shortness of breath. Deficiency also of cyanocobalamin, which is vitamin B12, can also lead to glossitis, ataxia, paresthesias, weakness, cognitive changes. This patient has ocular findings in addition to encephalopathy and gait ataxia in the setting of recent malnutrition, which is Wernicke. Okay, next.
A 38-year-old man with nephrotic syndrome due to minimal change disease become weak and oliguric over the 4-day period. Treatment includes sodium restriction, prednisolone, furosemide. Treatment includes sodium restriction, prednisolone, furosemide. His blood pressure is 110 by 70, 110 by 70 millimeter of mercury while supine and 90 by 60 while standing. Examination show no signs of systemic illness, no edema, urine analysis 4 plus protein, 4 plus protein, no blood, 5 to 10 WBC. Which of the following is the most likely cause of this patient's weakness or and weakness and oliguria? Partial hypertension is present. Partial hypertension, what partial hypertension indicates? Isn't it volume depletion?
I think so. The vascular volume depletion.
Like
Give
there
me
is clear, I don't know, Joe, because these days I do lots of mistakes.
no. Yeah, it's probably
I,
volume depletion.
I try to, uh, what can I say? I try to make a point why it is the answer. That's why I try to discuss with you. Okay.
Yeah. But don't do it during the exam. Don't try to stay there and try to think why is this the answer. Just pick one
No,
and
no.
move on.
Yes,
Okay, okay.
yes.
I hope you're just doing it because you are with me. Don't do it during the exam.
N- Now I can think. The whole
Yes.
day I have been able to do 10, 15 questions.
Oh God.
So I got so much blank these days.
Ah. Well, you were right. It's intravascular volume depletion. Orthostatic hypotension is defined as reduction of 20 or more in systolic BP or a reduction of 10 or more in diastolic BP when moving from a supine to a standing position. Typically, the decreased preload that occurs when a patient moves to a standing position is compensated by increased sympathetic drive, raising heart rate, and increasing vascular tone to prevent hypotension from decreased preload and stroke volume. However, this mechanism can fail to provide adequate compensation in the setting hypovolemia, autonomic dysfunction, and neurodegenerative disorders. Symptoms of orthostatic hypotension include lightheadedness, blurring of the visual fields, and syncope. This patient has orthostatic hypotension after diuresis. After diuresis, who said that? Oh, which makes intravascular volume depletion the most likely cause of this patient oliguria. How do you know they had diuresis? Okay. It's not B or C because acute ischemic renal failure is often seen in shock syndrome caused by decreased renal blood flow leading to tubular injury. Characteristically, this presents with worsening renal function associated with muddy brown cast or urinalysis. This patient has orthostatic hypotension and proteinuria, which will not be classic for acute ischemic renal failure. Okay. Acute renal vein thrombosis most commonly present with flank pain and hematuria, often in patients who are hypercoagulable. Is a rare complication of nephrotic syndrome, but does not cause proteinuria on its own. This patient has significant proteinuria associated with oliguria and orthostatic hypotension, making intravascular volume depletion a more likely cause. Okay, next.
Okay. A 23-year-old a 23-year-old man with a type 1 diabetes mellitus admitted to the hospital 2-day history of nausea, vomiting, and diarrhea. He has also had increased thirst and urination. During the past 2 hours, he has become tired and wants to sleep. He has not taken insulin 24 hours. Temperature normal. Pulse 102. Respiration 26 per minute. BP 100 by 60 pulse oximetry on the room air shows oxygen saturation 100%. Skin examination show no abnormalities. Lungs are clear to auscultation. Heart sounds are normal. Bowel sounds are decreased. There is no organomegaly or tenderness on neurologic examination. The patient is solvently the patient is solvent but easily aroused and fully oriented. Hemoglobin is 15.5, hematocrit 50%, leukocyte 13,500, segmented neutrophil 70%, lymphocyte 30%, sodium 130, potassium 5 point. Potassium is high, chloride is slightly low, bicarbonate is very low, 10, the blood urea nitrogen high, glucose is very high, and creatinine is 1.2, pH 7.13, PCO2 is low, okay, and PO2 is 98. So looks like when okay, a X-ray shows no abnormality. A ECG shows sinus tachycardia. Which of the following is which of the following is most likely acid-base disorder? Um,
Nausea, vomiting, diarrhea. Mm, 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 mm.
isn't it decay?
Mm, right, yeah. Metabolic acidosis, anion gap metabolic acidosis, metabolic and respiratory acidosis. No, and metabolic alkalosis, no. Okay. Ready?
Yes.
Okay, let's see. Um, This patient lab and arterial blood gas evaluation discloses an anayoga metabolic acidosis identified by pH less than 3.7.35, which is acidemia, with decreased bicarb concentration and decreased PCO2. Metabolic acidosis describes a derangement involving excess acid and is subdivided into anion gap and non-anion gap categories. Anion gap, sodium minus chloride plus bicarb, calculates unmeasured anions in serum which are contributing to acidity, lactates and ketones, where non-ion gap acidosis generally results from excess supply of protons of chloride. Retention of protons of chloride by the kidney or failure to secrete uh, bicarb buffers. This patient anion gap metabolic acidosis is most likely caused by diabetic ketoacidosis, given his history of missed dosing of insulin, and symptoms of nausea, vomiting, diarrhea, hemoconcentration, and increased blood glucose concentration. Pathophysis includes a relative absence of insulin, which prevents cell from utilizing glucose, leading to hyperglycemia, polyuria, polydipsia, in addition to ketone formation. Treatment includes IV hydration, insulin therapy, and electrolyte correction. Other common causes of anion gap metabolic acidosis include lactic acid, uremia, ethylene glycol, methanol ingestion, salicylate poisoning, Winter's formula, which is PCO2 1.5 times serum bicarb plus 8 minus plus or minus 2 can be used to determine if there is appropriate concentration or if a secondary acid base deficit is also present. Oh, I want to read A and B. Sorry, B
Yes.
and C. Anion gap metabolic acidosis and metabolic alkalosis can be determined by delta anion gap over delta bicarb ratio. Jesus. This is calculated using the formula patient anion gap minus normal anion gap over normal by car minus Jesus Christ. A delta delta ratio below 1 indicates a concomitant non-gap metabolic acidosis, whereas a ratio above 2 typically indicates concomitant metabolic alkalosis. This patient has an anion gap of 26 with a delta delta ratio approximately 1, which indicates that he has a single acid base. So I'm definitely never going to remember this shit. This is no. Anion gap metabolic acidosis and respiratory acidosis will be indicated by acidemia with decreased bicarb concentration, um, acidemia with decreased bicarb concentration, and increased PCO2 concentration. Okay. This patient PCO2 concentration was decreased, arguing against respiratory. Okay. There is some degree of respiratory compensation with metabolic acidosis, with Winter's formula being used to determine if appropriate respiratory compensation is occurring. This Winter formula yields an estimated of PCO2 21 to 25, and his is 23, indicating appropriate respiratory compensation without a secondary respiratory acidosis, which will be marked as PCO2 above 25. Okay, I mean, okay, 46.
Yes. A 72-year-old woman is brought to the ED because of 8-hour history of severe crushing left-sided chest pain radiating to the neck and the arm. She has no history of similar chest pain. During this time, she also had shortness of breath and dizziness. She has hypertension and hyperlipidemia, has no allergy medications, are hydrochlorothiazide and lovastatin. She appears uncomfortable and in moderate distress. Pulse is 120 per minute, blood pressure 98 by 60. Pulse oximetry is 6 liter per minute by the nasal cannula. Show oxygen saturation is 92%. JVD is 10. Carotid pulses are 2 plus equal to the normal upstroke. Crackles are heard halfway the lungs bilaterally. Cardiac examination show S3 gallop. Abdomen is non-tender. There is 1 plus edema to the mild cough bilaterally. Which of the following is the most likely diagnosis?
Ready?
Yes,
Hmm. Where is it? Why is my thing not working? Okay, so it's cardiogenic shock. This patient presentation is most consistent with cardiogenic shock after a MI. Crushing chest pain with radiation to the neck and arms, dyspnea, and risk factors for cardiac disease, hypertension, hyperlipidemia indicate that this patient is most likely having an MI. During and following an MI, cardiogenic shock may develop depending on the amount of cardiac muscle that is infarcted. If a significant portion of the left ventricle is infarcted, cardiac output will fall secondary to a decrease in ejection fraction and stroke volume. To compensate, the heart rate will increase to try to maintain BP. However, the inability of the heart to pump blood forward causes dilation of the left ventricle, okay, with the S3 sound, and pooling of blood with increased pressure in pulmonary veins and capillaries, leading to pulmonary edema with consequent crackles and hypoxemia. Further fluid backup into right-sided circulation leads to peripheral edema and increased JVP. Treatment includes initiation of inotropic agents to augment the cardiac output and treatment of the underlying conditions, such as placement of a cardiac stent in the patient. Mechanical support, intra-aortic balloon pump, indwelling impeller device may be required to take over mechanical function if medical therapy and revascularization are unsuccessful. Okay, let me read the other ones. Acute aortic insufficiency can lead to symptoms like those of cardiogenic shock with dilated left ventricular pulmonary edema and peripheral edema. However, acute aortic insufficiency is not a common complication of MI. Additionally, it will be associated with diastolic murmur heard at the upper sternal border, which is not present in this patient. Okay. And then it's not B because acute papillary muscle rupture can be associated with MI and leads to acute mitral regurg with subsequent significant pulmonary edema. However, this finding will be associated with a harsh systolic murmur on exam rather than S3 gallop. Oh, okay. It's not cardiac tamponade leads to obstructive shock caused by large pericardial effusion that prevents necessary amount of preload from entering the heart. This decreases the output of the heart and leads to similar clinical presentation as cardiogenic shock. Cardiac tamponade is classically associated with muffled heart sounds, increased JVP, and hypotension. This patient has a S3 rather than muffled heart sounds. Makes sense. Hypovolemia, when significant, can lead to shock secondary to decreased cardiac output. However, it's not a common complication of MI and would not be expected to present with signs and will not be expected to present with signs of volume overload such as crackles and all that. Okay, next.
47-year-old, sorry, uh, 67-year-old man comes to the physician 6 hours after the onset of fever and lethargy. She has a dysuria for 3 days, no medication, somnolent, temperature 102, pulse 106, respiration 36, BP 88/60, mucous membrane dry, neck is supple, lungs are clear to auscultation and percussion, hematocrit 32%, leukocyte 4,800, neutrophil 67, bands 22, and low platelet is 70,000. Urine analysis show numerous leukocytes and gram negative bacilli. An X-ray chest shows no abnormality. Blood cultures are ordered in order to IV administration of 0.9% sodium chloride. Which of the following should be administered intravenously? It is not septic shock, isn't it? Oh,
Mm,
urine analysis show numerous.
when do you do platelet? When do you
Platelet
give platelet? When is below how much? Is it 50 or
50 or
30?
20,000 as far I remember. Like
Okay.
even if 50,000 usual platelet is not given. Is it like septic shock? Like
Probably, yeah.
okay.
Mm-hmm. Ready?
Yes.
This antibiotic septic shock is a marked inflammatory response to a known or presumed infection. If left untreated, it can progress to septic shock with profound vasodilation and decreased organ perfusion, leading to demand ischemia, lactic acidosis, encephalopathy, acute kidney injury, transaminitis. Sepsis classically present with leukocytosis with a neutrophilic predominance, tachycardia, fever, signs of underlying infection, whereas septic shock presents with these same symptoms plus hypotension and an increased lactate. Common causes of septic shock include UTI, pneumonia, abscesses. This patient has a UTI as evidenced by gram-negative bacilli urinalysis and symptoms of dysuria, which is the leading cause of the septic shock. Prompt treatment of sepsis is needed to prevent mortality. with treatment including hemodynamic support with fluid resuscitation and vasopressors to maintain other perfusion, antibiotic treatment, and source control. It is pertinent that this patient receive IV antibiotic as soon as possible to prevent worsening of his septic shock. Okay, DE. Platelets are not indicated in this patient. Gram-negative infection can lead to thrombocytopenia. However, platelet transfusion is not recommended until it falls below 10,000. Okay, unless until the platelet count falls below 10,000, unless the patient is bleeding. Whole blood is rarely used in clinical medicine. When used, is most common during massive transfusion protocol to provide a patient with balanced transfusion of RBCs, platelet, and plasma in the setting of traumatic hemorrhage. This patient is um, only mildly anemic and thrombocytopenic and will not benefit from whole blood transfusion.
Okay.
Okay, next.
A study is conducted to assess the usefulness of serum BNP concentration as a diagnostic test for CHF. Subjects include older than 18 years of age who come to the emergency department because of shortness of breath. A serum BNP concentration is measured in each patient, and a clinical diagnosis of CHF is determined by two cardiologists through the review of the medical records. Chest X-ray mention results of bedside echocardiography. A graph shows sensitivity and the specificity of the BNP. The presence of CHF at five different serum BNP concentration A to E. Which of the labeled point does this test perform with best combination of sensitivity and specificity? What they are asking, at which level point does this test perform with best combination of sensitivity and specificity?
Hmm.
How you were thinking?
Which one has high both sensitivity and specificity? So
So
sensitivity, you can see here, it's the higher will be the 100. So it will be ones that are up there. Specificity, I think that you go this way instead of that way. I'm thinking. So it will be either 20 um, or I mean, sorry, B or C. Um, I don't know the difference between. I'm thinking it's B, but is that I'm between B and C.
okay, you pick one, I pick one. You
Okay,
haven't
sorry.
choose one.
It's I did. It's B. I chose B.
Okay,
Mhm. Mm, okay. Ready?
yes.
Yeah. Sensitivity and specificity are important concepts to understand when you determine which diagnostic tests to use and how to interpret them. Sensitivity refers to ability of a test to correctly identify people that have the disease, whereas specificity, ability of a test to correctly identify people that don't have the disease. In a patient population with low prevalence of the disease, a negative result on a highly sensitive test can rule out the disease because there is a low rate of false negatives. Jesus. However, a positive result on a sensitive test must be verified by a high specific test, which will have a decreased risk for false positive results. Therefore, sensitive tests are often used for screening and as in this patient, but must be verified by specific tests. In this case, the best combination of sensitivity and specificity will be B. It has similar sensitive and it has similar sensitivity as point C, D, and E, with much better sensitivity than point A. However, it has better specificity than point C, D, and E. What?
You have to make me understand what they
What?
are talking about.
Wait, I got lost when they tried to explain it. Wait, I thought I understood, but now I'm like, okay, wait. In this case, the best combination. I need the graph.
And this is the ROC curve. They are talking that the plot is shown is ROC curve. You
Yeah,
so
yeah. Oh my goodness. Okay, it says. I think we need to understand this one.
I think that
Uh,
we need to start from below the ROC one. Then
okay,
we can move
one.
forward. Yes.
The plot shown is known as the ROC curve. It illustrates the diagnostic ability of a binary classification test as discrimination levels change. ROC curves illustrating effective tests tend to be initially very steep in slope and then nearly flat, with an inflection point near maximal sensitivity and specificity, as seen in here at point B.
Okay,
By
you
contrast,
got it.
no.
Very steep in slope and then in nearly flat. The look at the from B to C.
No, I understand that part, but what does that mean? I understand the steep and then flat. Okay, but how does that help you on the question?
Okay, they go on.
By
Uh,
contrast, the more unitary the slope of the ROC curve, the less successful it is at balancing sensitivity and specificity at any discriminatory level. An ROC curve for an effective test appears strongly asymptomatic on two axes, whereas tests without reasonable balance of high sensitivity specificity will have a slope close to one. I don't understand. I didn't understand nothing on that last one, that paragraph. I really did not understand anything on that one. Because here it says, in this case, the best combination will be B, because B has similar sensitivity as C, D, and E. Okay,
what
let's
does it
look.
mean?
B has similar sensitivity as C, D, and E, which is true, because
Yes.
B is right here, it's like 80
Yes.
something sensitivity, and C is like 80 something or 90, and D is like, so they all have high sensitivity. Makes sense. Fine. With much better sensitivity than point A. So B has much better sensitivity. That we know that B has
Yes.
80, A is like what, 50? I don't know. So we that makes sense. However, it has better, so B has better specificity than point C, D, and E. Has better specificity. So this B has better specificity than point C, D, and E,
Why?
which is because here is the specificity, but it's
Okay.
one minus specificity. So the higher will be on this side instead of that side.
Okay.
Yeah. So you see, if so E will have a low
Low
specificity
specificity.
because it's on this side. D will
Even if
have,
it has higher sensitivity.
even if it has science sensitivity, exactly. Because here is just the one minus specificity. So instead of going bigger here, it goes bigger here. So high here. Yeah.
Okay. Now it fits.
Now it makes, yeah, because this other thing that they explain right here, I don't understand what they mean. The ROC curve thing. Okay, next.
Hmm. Okay. 49. A
Mhm.
42-year-old woman comes to the office for a routine health maintenance examination. She has no history of serious illness, takes no medication. There is no family history of cancer. Physical examination, including pelvic examination, shows no abnormality. The patient asks the physician about testing for ovarian cancer. Her friend was recently diagnosed with ovarian cancer, and the patient heard about a blood test to detect it. Research on this test shows a likelihood ratio is 1. Which of the following is the most appropriate physician response?
Jesus Christ, I forgot the whole livelihood already.
The test. Okay.
Yes. Okay, so a positive likelihood ratio is the likelihood that a patient with the disease will have a positive test result compared to the likelihood that a patient without the disease will have a positive test result. Huh? Wait, wait, let me wait. Okay, positive likelihood ratio. Patient
I'm
with
there.
the
You can read multiple times.
positive likelihood ratio. Patient with the disease will have a positive result, and patient without the disease will have a positive test result. Okay, so it's the positive. It can be calculated by dividing the sensitivity, oh Jesus, by 1 minus specificity. In contrast, the negative likelihood ratio is the likelihood that the patient with the disease will have a negative result, and the patient compared to the likelihood that the patient without the disease will have a negative test result. It can be calculated by 1 minus sensitivity over specificity. Jeez. Likelihood ratio greater than 1 increases the post-test probability greater than 1, whereas a ratio less than 1 decreases the post-test probability. In this case, a likelihood ratio of 1 indicates that the test will neither increase nor decrease the post-test probability. Okay, meaning that it will not be useful in diagnosis of ovarian cancer in this patient. Okay, makes sense, I think. Let me read deeply. This test can tell us if further testing is indicated for ovarian cancer. May be an appropriate response if this patient had an increased risk for ovarian cancer and the test had a likelihood ratio greater than 1. Okay. She has a low pretest probability of ovarian cancer given her lack of symptoms and family history, as well as age. But if she were to have a greater pretest probability, a positive result on the test will have, with a high likelihood ratio, will indicate the need for further testing. Okay.
So why it is the answer?
Because it's 1. So basically, if it's more than 1, then your whatever probability that you say is true. If it's less than 1, whatever probability that you say is not true. If it's 1, then there is no, it's inconclusive.
Okay. And another thing, like you remember these things like sensitivity and regarding positive predictive value and specificity. You got my point.
No,
Like that this test is sensitive. So is it true positive or false positive? There is a relation. You have said it previously. I don't remember actually. Okay,
I don't know.
we will find out later
Yeah,
on.
remember. Okay, next.
77-year-old woman with 2-year history of stage 4 ovarian cancer is brought to the physician by her children for consultation. Initially, she underwent cytoreduction and combination chemotherapy with carboplatin and paclitaxel. 6 months after completing chemotherapy, testing showed that the cancer had recurred. She now had metastatic disease to the spine. Despite during chemotherapy regimen, doxorubicin, topotecan, cyclophosphamide over the past year, she has been confirmed to bed. She appears extremely ill and is in respiratory distress. She is alert, oriented, rates her pain to 10 on 10 pain scale. Examination show large supraclavicular lymph node, bilateral pleural effusion. Abdominal examination showed distension with ascites and a large fixed ventral mass. She does not want further cancer therapy, but her family demands further treatment. Which of the following is most appropriate next step?
Ready?
One second.
Mm.
Um, okay.
IV morphine therapy. One of the core tenets of medical care is autonomy. Or patients want to make decisions for themselves. This patient has terminal metastatic cancer and has failed multiple treatment. At this point, transition to more comfort-focused healthcare approach will be reasonable and in line with patient goals. As a terminally ill patient approaches the end of life, he or she may decide to focus on quality of his or his remaining life rather than increasing the quantity of time remaining. This often allows them to avoid further invasive diagnostic and therapeutic intervention and to instead be as comfortable as possible for the remainder of their life when addition of therapy would not meaningfully extend the quantity of life remaining. For this patient, the most appropriate next step would be to provide adequate pain control with IV morphine therapy so that she can be as in little pain as possible until death. Occasionally, family desires are consistent with patient desire for the care are inconsistent with with patient desires. If the patient has capacity to make medical decisions, his or her his wishes should be honored rather than those of the family. The physician should explore reason for discrepancy, especially in cases where values may have recently changed or in cases of impaired capacity, but bearing an ethical uncertainty, patient wishes should be honored. And it's not psych assessment because aesthetic psych assessment would be inappropriate. This patient has no sign to suggest that she is incapable of making informed decisions regarding her goals of care. With progressive metastatic terminal cancer, the decision to forego further attempts of life-sustaining treatment to focus on quality of life would be a reasonable decision. Okay, we are done.
Okay.
Okay, we want to take a break
Yes. We will
and
start.